Hey guys, this week is going to be about dysphagia. For the record, something that you guys would have no clue about. This is actually my second take of this video. Probably end up being a better deal for you guys, but I did the first recording. It was 54 minutes long, and for whatever reason, the video didn't work. So here we go. So the videos that I've attached, found on the internet, are going to be basically what you're going to get out about as far as the function of dysphagia. What is dysphagia? There's a couple things from the ASHA website that I'm putting on there, and I'm just going to leave it at that. I mean, again, at undergraduate and graduate level courses on dysphagia. So actually I didn't have one in my undergraduate, but a whole course in graduate school on dysphagia in itself. So there's obviously tons to learn about it. What we're going to cover though is what your role would be as an SLPA going into a situation working with a person with dysphagia. In my opinion, in the work that I do in a skilled nursing facility, an SLPA would be super, super valuable for me to have one of you guys that have just this 1 week little quick hitter of information on dysphagia, but actually working with me and observing and seeing what dysphagia is like to work with. It would be so valuable if I had a quarter for every time that I sat with a person and just simply observed them while they're eating and was watching for certain things. I would be rich, but I'd have money because I do it a lot, working with people with dysphagia. So basically what I'm trying to communicate is an SLPA's role with helping an SLP working with dysphagia is really, really valuable in my opinion, and I think you guys would be able to provide a really good service. I've given lots of different trainings in my time as an SLP, especially to the nursing staff, people helping the feeders at nursing homes. Oftentimes it ends up being a lot of like high school kids, but so I've given training on dysphagia quite a bit over the years. So I'm just going to cut to the chase. I'm going to try to keep it pretty organized as far as what I'm talking about. Your job, well, we're going to start there. Your job as an SLPA, if you were assigned to work with a person with dysphagia, observing them at mealtime, okay? There's several things that you'd be looking for. Number one thing that you're going to be observing is if you're working with a person with dentures, that they have dentures. If they're a person that has had some kind of a stroke and they have where they're tipped over, that they're sitting in an upright position. If they're in a wheelchair, that their chair is up as high as it can. Because when we're working with people with dysphagia, we want them in general to be as close to a 90-degree position in their chairs as they possibly can. So the first thing that you're going to be doing is checking for positioning. Number two, you're going to check to make sure that if they're wearing dentures, that they got their teeth. Hey, if they're gonna be eating, you're gonna make sure that they're gonna have their teeth. Okay, so then the next thing is that you're going to want to be familiar with the strategies that the person's been prescribed by the speech language pathologist. Oftentimes, the speech pathologist will prescribe positioning, posture for the patient while they're eating. The most common thing that I write is a chin tuck position. So what a chin tuck position is, if you can believe this, It's where they tuck their chin down towards their chest. I know, super confusing, right? That it'd be called the chin tuck position. It's a real common recommendation from a speech pathologist. The cue that you would use with a person that's been prescribed a chin tuck position is take your glass of water, patient, take a small drink, and swallow. So take a drink, hold it in your mouth, put your chin as tight as you can to your chest, and swallow. Sometimes you have to use cues of look at your plate, look at your feet. I've used it, and this is a good little tip for you guys if you ever get into this position, is making a little visual card for chin tuck. If the person is in a cognitive state, that would help, that you put right at their plate so they can be reminded that every time that they swallow, and they get their chin down tight to their chest. Quick explanation on a chin tuck. Chin tuck are used for people that you're expecting, or the SLP is expecting that there's residuals. Residual means anything that's left over after a swallow. That's a residual. Sometimes residual are in the oral cavity, and sometimes residuals are in the laryngeal vestibule area close to the airway. Sometimes it's right at the base of the tongue. So residuals can be all over the place. A chin tuck, in theory, if a person has residuals on by the base of their tongue, maybe in their vallecula area, in theory what happens is the person swallows and the residuals get caught by the liquid and get washed down. The other thing that happens is just the physiology of when you assume that chin tuck position, what ends up happening is the base of the tongue squishes the epiglottis back. And so when a person swallows with the epiglottis already folded back with the chin tuck, in theory it provides a straighter shot for whatever's being swallowed to get into the esophagus. And the other thing that happens, and this terminology might be above you, I'm sorry, but when a person assumes that chin tuck position, what also happens is the cricopharyngeal sphincter muscle, which is the muscle that sits on top of the esophagus. It's a sphincter muscle, right? When you assume that chin tuck position and you swallow, it naturally allows for that sphincter muscle to be opened wider. So with that sphincter muscle open wider, the cricopharyngeal, it's also known as the pharyngeal esophageal port, that chin tuck makes that port be open for a little bit longer of a duration, so more of the bolus can get in and swallowed. So two things with the chin tuck is helps with residual. I just did the middle finger thing. I do that sometimes. You got to be careful when you're doing articulation. You do 3, 2. I just did that, but so chin tuck helps with chin tuck helps with any residuals, washing them down, provides a straighter shot for whatever's being swallowed to get into the esophagus. And number 2 is protecting the airway more by having the epiglottis folded over the opening of your airway. It helps better seal the laryngeal vestibule with the epiglottis down, and it stretches that cricopharyngeal muscle, that upper sphincter muscle. It helps stretch it open so stuff can get down more. back to where we were at. So if you're eating with a person that has dysphagia, you're going to be checking for their posture in their wheelchair or chair, that they're sitting as upright as they possibly can. You're going to be checking to make sure they get their teeth in, and you're going to be making sure that you're familiar with what's been prescribed to them. Chin tuck position is the most common. Sometimes you have head tilts. The one video that I put on there, it's probably like a graduate student that did a decent job explaining that. So like, let's say the right vocal fold has been affected and it's not moving. So if you are able to turn the head to that side, the left vocal fold in theory is going to be able to make a closer abduction closure to this vocal fold on the side that's not working by tilting the head to that side. So you'd have to be able to cue the person into those positions. That's going to be important. Another thing that's going to be commonly prescribed when you're dealing with a person with a dysphagia is alternating a liquid with a solid, and it goes with the residuals. Again, for the most part, person chews a bite of hamburger, and what the cue often is you remind the patient, okay, once you get done swallowing your bite of food, I need you to take a drink of water, okay? And the reason that cue often happens is to help with residuals. What can happen is a person will be eating their solid food, their diet item, and they swallow, but they don't swallow it all. They got a little bit of residual down in their vallecula, and they take another bite, and they get some swallowed, but they don't have it all swallowed. So then there's more pooling in the vallecula area, and without a liquid wash in between, eventually that residual can build up high enough and fill the vallecula, where the next spot after the residuals fill the vallecula is into your lungs. So cueing, alternating liquid with solid is something that you're going to see if you're working with a person with dysphagia more times than not. And it's, again, if that residual is there, the person takes a drink, in theory the liquid's going to wash whatever residual might be down into the vallecula, and it will wash it down, and they'll be able to swallow it. In theory, that's how that works. So that's a common thing that's prescribed. Another thing that's commonly prescribed is small bites and sips. If you're dealing with a person with swallowing disorder, one of the best things that happen or you can do for the person is train them into not having as big of drinks. It's easy. People get in the habit of taking their water, and I don't know if you'll be able to see, but if you kind of look at my larynx, that's how a lot of people like to drink. I think it was 5 swallows that I just did in about a matter of, I don't know, maybe 3 seconds. That's a really, really high task demand on a body. And if a person's got issues with their swallowing, they're more than likely not going to be able to keep up with that, and that's where they're going to run into problems. So cueing the person into taking small sips, controllable sizes, is an important thing. And it's the same thing with bites. It's amazing on how that goes, but the bottom line is people have been eating the way that they eat forever, and everybody that you run into's got some little weird thing that they do when they eat. Like for me, my weird thing is I don't drink anything until I'm all done eating my meal. So when you start talking about alternating liquids with solids, small bites and sips, those are major, major changes that you're asking a person to make in their life. So you have to be assertive with the people without sounding bossy is probably not the right word, but without sounding like a prick, maybe would be the real blunt way to put it. You have to be assertive with them and know that the things that are prescribed for them are what's going to be best for them, and sticking to your guns and trying to get the person to follow your direction with that, with the small bites and sips. And at times that means that you need to physically take the person's hand and put it down. You need to physically, they take a bite, you need to physically put your hand on top of their hand and say, swallow that first. And it can be a really awkward deal. You obviously have to read your patient, but your job is to get them to change the habits of the way they're eating to help them best protect their airway when they're eating. So oftentimes there's a physical component to that of restricting the person from taking a big drink, restricting the person from taking a big bite. Hey, that's too big of a bite. It's a weird thing, to say to an 82-year-old, but I mean, you got to retrain the people so they know what's best for them. So now coming back to what we've been talking about here, checking posture, checking that they got their teeth, knowing what has been prescribed to them, whether it be a chin tuck position, whether it be alternating liquids with solids, whether it be small bites and sips. There's also other things that you're going to be watching for data for the SLP. You're going to be looking for oral leakage. Are they taking a drink and half of it runs down out of their weak side of their mouth? That's good data to have for the SLP. The next thing that you're going to be tracking for the SLP is pocketing. Pocketing means any food that's left over in the oral cavity that you can see. Oftentimes it's in the buccal cavity, which is the space between your cheek and your tongues. Oftentimes for people, it'll be way back by the molars. That happens when people lose control of their bolus, where they have a hard time managing it and keeping it in a cohesive ball. So the cue there, which is, it's not the most comfortable thing to tell people, but you got to say, hey, let me see in your mouth. Let me see in your mouth. I want to see if you got any food in there. And depending on the cognitive status of the patient, sometimes you can just ask them and they can say, yeah, I got food. If it's really severe, you can actually see it, where they look like a chipmunk, where they got so much food in their cheek that it's very obvious that they're pocketing. You'll run into that. Sometimes it's not as clear, so you have to ask them, hey, I got to look in your mouth, let's see what's in there. Whatever words you want to use, I typically will just say, hey, can I see in your mouth to make sure we're not pocketing any of the food? I'll usually be really direct, but tell the people why you want to look in their mouth. If people do have pocketing going on, you're going to have to teach them how to sweep with their tongue to get it out. If they can't do that, then you want to you want to teach them how to get their finger in and clear with the finger sweep. And depending on the cognitive status, sometimes you got to glove up. If you're working with a person with end-stage dementia, sometimes you got to glove up and get in there and sweep their buccal cavities out and clear whatever residual is in there. So, you're going to be looking for pocketing with the person. You're going to be looking to comment on oral leakage that they might be having. After the pocketing, the next thing that you're going to be commenting on is how long it takes them to trigger their swallow. You'll have times where it takes a long time for a person to trigger their swallow. What I mean by that is they take a drink, and it takes a while for them to trigger their swallow. Sometimes you need to palpate, feel their throat. If it's a heavier set person or an old person that's got quite a bit of skin here where you can't quite see their larynx as well, especially on older women that happens. We actually have to touch, but most of the time you can see the excursion of their larynx when they're swallowing, so you're going to want to be able to keep track of how long it takes that person to trigger their swallow. To trigger their swallow, that's really useful data for the SLP to know. And after the swallow's been triggered, then the next thing that you're going to be looking for is really overt signs that they may be aspirating. Number one is if they start coughing. That's the most obvious and overt sign. Sometimes if you start seeing increased runny noses, that can be a sign of aspiration. I'm not going to go into the more in-depth stuff, but because that's going to be the SLP's job. But you will be monitoring for those overt signs and symptoms of aspiration. And after once they've clearly swallowed, the next thing that you guys are familiar with that you're going to be tracking for the SLP is having the patient say "ah" after they swallow, because if there is residue that's residing in the larynx, whether it's the false vocal folds or true vocal folds, if there's residual in there, you're going to hear it when they go "ah," because it'll sound gurgly, it'll sound wet. Sometimes you can actually feel it if your hands are on their throat and they swallow. And if there's a significant amount of residue in the laryngeal vestibule, you can actually feel it rattle on your fingers. So you're going to be checking for that. If you are working with a person and they do have the wet quality, you're going to have them cough and swallow. You'll cue them. Give me a good cough and then swallow. Okay, let's do that again. And then have them do the "ah" to see if it still sounds wet or not. And another common recommendation from the SLP when you're dealing with a person with dysphagia is cueing the person for a second swallow. So that would mean you'd tell the person, okay, swallow, and then I want you to swallow again, okay? So you would go. We're cueing the person to swallow 2 to 3 times. And basically what you're encouraging is those multiple swallows to hopefully catch anything that might have not cleared on the first swallow to get cleared on that second swallow. And again, that's something that you got to be assertive. You and I are not used to swallowing 2 to 3 times after once we take a bite of our hamburger. You know what I mean? So you're really, really changing the dynamics on how a person's used to eating, so you got to be assertive with them. And then the final data thing that you'll be tracking is their intake. How much did they eat? Usually dietary will keep track of that data, but it's also something that it's pretty easy to say, hey, they ate 80% of their meal, or they didn't eat any of their meats. Okay? Those are things that you can track. So that's topic number 1 of this video, is things that you're going to be looking for when you're working with a person with dysphagia. Number 2, I'm just going to touch on it real briefly. Diet modifications. These are going to come right from the SLP. They're included in the videos. You got a regular diet, you got a mechanical soft diet, you got a parade diet. And a lot of times the SLP will make the recommendations on the diets based on their oral prep and their oral phase of their swallow. If it takes a person forever to get their food chewed up, they'd probably be better off with mechanical soft. If the person just has real poor oral control and can't keep a cohesive bolus, I mean, where it's real severe, they're probably going to be better off with a parade diet where, I mean, when you swallow pudding, it's pretty hard for that to get all over in your mouth. I've seen it in people that just have zero oral control. So those are the 3 diet modifications that can be made. This is a little awkward, but like I told you, this is my second step. I gotta plug my computer in real quick. Alright, so those are the diet modifications. Not going to go in depth with it, and then with the liquids, the reason that we modify people's liquids is that their body needs more time to prepare to swallow. I always will do an example with the patient, sometimes with the family, where I'll get a glass of thin liquid, nectar thick liquid, honey thick liquid, and oftentimes after honey thick liquid is spoon thick or pudding thick liquids. Not the best example, but basically the difference is the honey thick is more viscous than a nectar, which the nectar is more viscous than a honey thick. So the example that I like to use, and if you're ever in this situation, it's a real good one. Get a tray, put it at a 90-degree angle, and say, now let's watch. And you pour the thin liquid and it zips right down. You pour the nectar thick liquid and it goes a little bit slower. Pour the honey thick and it just kind of eases its way down. And basically, by doing that, it's a good visual to say to the patient, your body needs more time to get ready to swallow. By having the thickened liquid, it gives your body those few extra seconds, milliseconds, to get ready to swallow, and it's going to help keep your airway safe. I've used that example tons and tons and tons because it's visual and people can understand that, the visual component, a lot better. So yeah, I mean, I get it that I'm going through this stuff really fast, but it's about exposure to dysphagia. The last part of this video that I wanted to talk about is the seriousness of dysphagia. Dysphagia, people with severe dysphagia, it can kill them. It can be lethal. Because what happens is if a person has severe dysphagia that's gone unaddressed, and the person's not modifying anything on their own, they develop an aspiration pneumonia. Aspiration pneumonias are a bacterial type of pneumonia. They're more difficult to treat, especially in medical fragile people. Aspiration pneumonias are bad news for people, older people especially. Treatable, obviously, but can be a really, really bad deal. And they can be recurrent until a person's dysphagia has been addressed. So basically, well, an SLP has the power to control life and death. That might be a little bit overboard, but it's actually quite true. When you're dealing with a person with severe dysphagia, that the SLP gets in and makes the call on what diet's going to be best for this person to keep their airway safe. And I've done it numerous times, lots of times, where the safest diet for this patient is nothing. Their safest diet is NPO. They can't tolerate any food. They're not safe. Everything they eat is aspirated and they can't eat. Well, once the SLP makes that call that they're not safe to eat, then you have opened up the door to need for feeding tubes, alternative feeding methods, and it can be a real slippery slope, real tricky deal. Luckily for you as an SLPA, you won't have to deal with that, but it is something that exists for SLPs, and it's really common, you know. But where I was going to go with this next is, so you go in and you tell Jane Doe that, yeah, after your stroke, your swallow is not working so well, and your body can't tolerate thin liquids. You're aspirating on the thin liquids, and you're going to be better off on a honey thick liquid. And in your brain, as you watch this video, you might not really think of it that much, but think of it like, for me, it's like I love to drink coffee in the morning, and coffee is the way coffee should be, but now speech pathologist said I can't have that. It needs to be nectar thick. So basically, when the speech pathologist starts modifying diets, you're changing the person's life, because they've been eating the way they've been eating forever, and then you come in and say, can't be that way anymore. It's a real hard thing for some people to deal with, but you just got to know that you're doing the right thing, and that what you're trying to give to them is helpful. With that being said, it's so important that when you're dealing with a person with dysphagia, that you're treating these people with the utmost respect. You're trying to give them as much dignity as they can. It's a pretty undignifying situation for this person that had their stroke and they're in the nursing home, and they're sitting with 5 or 6 other people at their table, and the food's just running out of their mouth. They take a drink, and it's not their fault. You know, it's not that they want to eat that way. It's just the fact of the matter, and it's a really super undignifying situation for them. So it's your job when you're working with them to respect the person, give them as much dignity as you can, you know. Have that napkin there. If you see that they're drooling, clean them up. Take care of them. Yeah, and I think I've tried to really hit that home with you guys when you're dealing with these adults. You're dealing with the adult population. Treat them with respect. Treat them with love. Treat them with compassion. You know, treat them with dignity. Show them that you care by your actions and the things you do for them. Super important, and it's given me a lot of success in my therapies by just having that in the back of my mind, that this person has got a lot on their plate, and I'm going to go out of my way to make sure that they feel that I care about them and I want them to get better. So the last little part of the session of this video is a warning, because I see it all the time. When you're working with a person, it's important that you don't turn it into a social hour with them. I just was talking about treating with dignity and treating them with respect, but ultimately you're dealing with a person that's got a hardship in their swallow. And when you start trying to converse with them, you've really shifted a cognitive demand away from them really just focusing on how they're going to get the muscles to work to swallow. And now they're thinking about communicating with you, and really what they should be thinking about is how they're going to swallow safely. So it's important that you do interact with them, but you have to time your interactions. Don't ask them a question as soon as they put a spoonful of oatmeal in their mouth. You got to be careful, and you have to be cognizant of when you're going to ask questions and when you're going to talk to them. Okay? It's okay to visit with them, but you really, really have to be paying attention to when you're asking them questions. As far as therapy, I don't know why I do this so much, but I do. There's one of the websites, the 5.9 Treatment of Dysphagia. It goes through a list of different postural techniques and swallowing maneuvers. I am not going to go in depth with those because ultimately they're all self-explanatory, and the website there does as good a job, I guess, as you guys are going to need at this point in time in your careers on why you do it. But those are things that you might find yourself doing in a therapy with a person that you might be working with. So gosh, I just brushed on the basics of dysphagia, but watching this video and the YouTube videos that I've included, it'll put you in a position that if you do find yourself working in a skilled nursing facility or a hospital, you're at least going to have some background knowledge, something in your brain that you're going to be able to reflect on. And down the road, if one of your loved ones has a stroke and has some dysphagia, you're going to have some resources that will hopefully prove useful. So that's going to conclude the video on dysphagia.